Hello, everyone. My name is Nicole Bustamante, and I work in the communications department here at the Global Fund. Thank you for joining today's webinar on the updates to the information notes. There will be 5 sections, which you'll see in the next slide, during the presentation, detailing the updates to each of these information notes. We will also introduce 2 new approaches, which include program essentials and critical approaches. The time allotted for each session is listed on the agenda slide here, and each section will be followed by 10 minutes of Q&A. We invite all attendees to enter any questions that they may have in the chat, and we will collect these. I will now hand over to our first section on program essentials. Thank you.
Good afternoon, everybody. Please, next slide. So, as you probably know, we are going to be introducing program essentials for the first time for this next cycle. And program essentials are key evidence-based interventions and approaches that are going to be used to address the ambitious goals that were set for HIV, TB, and malaria global strategies. The program essentials are, like I was saying, for the 3 diseases, and they are based on WHO recommendations and other technical partners recommendations. So they are strongly based on evidence. Yeah, we think that by implementing these program essentials, we are going to be able to reach our collective goals, and that we are going to be promoting equity and ensure access to everybody to life-saving interventions. Next slide, please. So how are the program essentials are going to be used in the next funding cycles? So the countries are going to be discussing and evaluating what is their level of advancement towards achieving the program essentials. They are going to be identifying which gaps they have, and then they are going to decide which one of these they are going to be addressed either via the Global Fund funding request or any other funding sources, because program essentials don't necessarily have to be funded by the Global Fund. They can be funded by other means as well. Once they decide these program essentials can be embedded into the funding request, then the funding request is going to be evaluated like TRP, like it's usually done by TRP, and if approved, it's going to be monitored. The program essentials are going to be monitored throughout the circle, the grand circle, in the same manner all other activities are. Next slide, please. So this is how the countries should discuss program essentials. Basically, it's important to discuss this during country dialogue to see if all program essentials are, what is the level of advancement of program essentials in country, and to see which other eligible interventions are going to be needed to be included in the funding request. So after all these discussions, some of the interventions are going to end up in the funding request. We know that we are not going to be able to fund everything in the funding request, so some of the interventions, either program essentials or other eligible interventions, can end up in the PAR as well. Next slide, please. So how this is going to work? Like I was saying, first of all, the program essentials will have to be discussed during country dialogue. Then there has to be made a decision on what is going to be embedded into the funding request. Countries are going to be filling there for HIV and TB only, not for malaria, what is called an essential data table. And this essential data table are going to be able to reflect how advanced they are in every one of the program essentials. Yeah. Then also in the funding request, program essentials are going to be addressed. Then during grant making, after this funding request has been approved and reviewed by TRP, during grant making, the program essential activities are going to be embedded into the grant to make sure that they are there. And then we are going to be tracking the implementation like we do regularly with all other grants. There's not going to be an extra mechanism for this. Next slide, please. This is an example of the essential data table that I had referred previously. This is a very small example for a few of the HIV program essentials. And as I was saying, this essential data table only has to be filled for HIV and TB, not for malaria. So here, what we would like to see is, are the policies addressing these program essentials in place, yes or no? And then what level of implementation we have. For instance, Pre-exposure prophylaxis is available to all people increased risk of HIV infection, and post-exposure prophylaxis that is available for those eligible. First of all, is there a policy in place in the country? Yes or no? If there is a policy, then what is the level of implementation? Is this a pilot? Is this in only a selected facilities, or has this been reaching all eligible facilities? Next slide, please. So these are the frequently asked questions that we have on Program Essentials. So must countries use Global Fund grants to address or make progress toward achieving Program Essentials? No, not necessarily. The countries can fund Program Essentials via other means, either using their own funds or other partners' funds, such as PEPFAR, USAID, etc. What happens if a country disease program does not fulfill the Program Essentials? So what we think is that this is a platform for discussion with national programs and other country stakeholders to see where these key interventions are being or not addressed. And then they can be discussed what is going to end up being funded by the Global Fund and inside the funding request, and what of the other Program Essentials are going to be funded by other partners or by the national programs. What we would like to see is a progression. It's to see that the Program Essentials are being followed and that there is a progression, and this is not only one side, and that we see an increase in coverage.
Celeste?
Yes?
We've received a request from the translators. If you could please adjust your microphone slightly. They're having a hard time hearing everything. Thank you.
Can they hear me there?
Please proceed, and then if we need to adjust, I will pop back on. Thank you.
Okay. So then how should countries use Program Essentials during country dialogue? It's like I was saying, countries should just see what level of advancement they have on each of the Program Essentials, and to see which ones are going to be funded via the Global Fund and which ones are going to be funded in other means, and to see what level they want for expansion on this particular Program Essentials. Yeah. Will progress against Program Essentials be tracked throughout the grant cycle? Yes, they will. They will be tracked the same way we do with any other activity or interventions via the indicators, regular indicators. Are there Program Essentials for RSSH? No, there are no Program Essentials for RSSH. They are only for HIV, TB, and malaria. However, RSSH has developed a set of critical approaches that are slightly different from Program Essentials, and that we are going to have more information later in this session. Over.
Thank you, Celeste. So now we have the questions and answers. I believe we have one question from the chat on the next slide.
Yes.
And I'm thinking perhaps, David, would you be able to speak to this one? I can read it aloud. It's from Leila. 2 questions. When can we expect the 2023 eligibility list to be published? And after the board meetings last week, do we have any further clarity on when we can expect the allocations to be sent out?
Yes, thank you so much. So the current estimate that we have for the 2023 eligibility lists is early December. For the allocations, those will be later in December. We will start sending those out towards the end of the month. We do have a webinar session that is scheduled soon. For those who have already registered for it, you will shortly be receiving a letter from me saying that we will be rescheduling that, but you will be able to learn all about allocations in our webinar that we will be holding, I believe, on December 20th. So we look forward to sharing more with you then.
Thank you, David. And we have another question in the chat. Celeste, perhaps that could be for you. We're adding it now. One moment.
Program essentials are relevant for all countries. Some of the funding requests, they will have a place where the funding request in the narrative for high impact and core countries, they're going to have a special place where if a program essential is not filled, is going to be given that space in the narrative to give explanation as to what the plans are to achieve this program essential. This is not the case for focus countries, but yes, it is relevant for every single country. Yes, I'm seeing the third question from Amaha. Could program essentials be funded by both Global Fund and other partners? Yes, definitely. They can be funded via other means, PEPFAR, USAID, or other funders, definitely. I will need a translation for question number 4 as it's in French, sorry. Question number 5 is any mechanism being developed to facilitate adoption of new drugs and technologies? Yes, you will see in the program essentials, there are some that are specifically for adoption of new drugs. For instance, in tuberculosis, you are going to see the emphasis on shorter TPT regimens, on also shorter DRTB regimens. So it is there as well. Also for technologies as well, for instance, use of WHO recommended molecular based tests is also one of the program essentials. So yes.
So we will ask our interpreters to please read aloud to us question number 4, please, into English.
Yes, so question number 4. Hello, in a context where there is more and more talk about a triple elimination among pregnant
women.
Well, yes, we are translating.
I can help. I mean, it's about triple elimination and funding of integrate the co-infection of HIV, TB, HIV hepatitis, and HIV syphilis. And I know my colleague Lee, I think she's raised her hand and she could probably answer to this question. And let me just briefly summarize. Yes, but maybe Lee can explain in more detail. Lee, are you there?
Yes.
Go ahead, Lee.
Have we lost?
Hello, can you hear me?
Yes, very vaguely.
Yeah, go ahead.
Okay. Can you hear me now?
Yes,
Yes.
yes, we can.
Wonderful.
Thank you very much, and thanks for the question. This is very important as the Global Fund strategy has really pushed all of us to think about integration of HIV service delivery across the continuum from prevention, testing to treatment, and that includes focus on triple elimination, as well as I can see hepatitis, and that includes hepatitis B and C, and STIs in its generality. We also are focusing on integrating HIV service delivery in HIV platforms for cervical cancer, NCDs, and mental health as well, in line with the WHO most updated guidelines. You will see this in the HIV information note in the relevant section that my colleague will touch upon in the next session, but also on a standalone guidance note that's going to be called Health and Longevity that will be published by the end of December. Thank you very much. I will put that in the text as well, David.
Thank you, Lee. I think we are up to all of the questions in the chat. So unless there are any others come through, I'm proposing we move on to the next section. Unless Celeste, you would like to share any other key messages.
The program essentials are listed in the information notes, so please take a look at that in the information notes. Thank you very much.
Thank you, Celeste. And I see we're having a bit of technical difficulties, so I'll just share the slides in a moment, and we'll move on to the HIV section with Annette.
Yes, good morning, good afternoon. I'm not sure exactly where you're sitting. So I'm Annette Reinich, and I'll be speaking to the information node, and I will then hand over to my colleague Aura, who will speak to the modular framework. And as you realize, my colleagues from the HIV team are also here to support me in responding to your great questions that actually already have started to come in. Next slide, please. Next one. Yes, thank you. So the Global Fund Secretariat has made available a number of resources that applicants should consult when developing their HIV funding requests. So these include the HIV information node, the modular framework, both of which we will be presenting now, then the other information nodes, which my colleagues will present right after me, and technical briefs. And this, of course, is in addition to the materials that are included on the Global Fund website with applicant guidance materials. And just for your information, at this point, I think nearly all materials have been translated into French and Spanish. And of course, these translations are also available on the Global Fund website. In the 2023 to 2025 allocation period, there are new opportunities to leverage advances in HIV prevention and treatment and to adopt precision public health approaches. The new Global Fund strategies and Global Fund strategies and guidelines spell out these opportunities, which are also reflected in the HIV-related guidance materials. And it's important to note that all these materials have been developed in collaboration with our key partners, and they're fully aligned with HIV-related global strategy and latest technical guidance. Regarding the essential data tables, there are now 2 tables to complete, which is the continuation of the indicator tables and the program essentials, which you just heard about, and Celeste presented those to you. The indicator tables continue to be pre-filled by the Global Fund, and where available now include additional baseline data and disaggregation. These are typically dealt with by countries' M&E teams, but the program essentials are best completed by program staff. Next slide, please. Yes, the HIV information node provides guidance to applicants preparing funding requests for HIV and joint TB/HIV programs for the next allocation period. It describes a strategic investment approach, defines the program essentials that all applicants are expected to address, and it identifies the prioritized interventions to have an impact. And we were pleased to hear from countries that they would like to hear country examples. So based on this request, we have included good practices for investments in HIV in the last section of this new information node. Next slide, please. As for NFM3, this information node includes a section on the investment approach. It outlines the following stages of a strategic investment approach, which is to understand in detail the epidemic, to design an evidence-based response, and to deliver quality interventions and approaches in a sustained manner. The recommendations, of course, provided in this section should be adapted to the country-specific context. All the countries that are applying to the Global Fund, there are different stages in the epidemic, and the epidemics will change according to the response. So yes, please use the data that you have available. If there are not enough data, please collect more, and then you shape the response in line with these data and the evolving epidemic. Next slide, please. In the same section under Deliver, we communicate our vision on the products and technologies for introduction and scale up in the next allocation period in Global Fund supported programs. This is new and important because new health products, tools, and technologies for HIV prevention, diagnosis, and care offer great potential for impact, and they should be considered and planned for in the funding request. And of course, we know that there are concerns about the cost related to new products, particularly in view of the limited resources. For innovations with higher product costs, national programs should holistically assess the impacts of new products, going beyond straightforward commodity cost calculations and accounting for the impact on the broader health system. And for innovations entering the market at a relatively lower cost, budget efficiencies, whether they are from commodity cost or health system, they can likely be realized and redirected toward other priority HIV problematic areas. I would also like to highlight that the products presented in this table, and you will see in the presentation and of course in the information note, a much more detailed table. This is just a high-level summary. But these products that are presented in this table, they add to the range of already existing proven effective products, such as condoms, that the Global Fund, of course, will continue to support. Next slide, please. Now I'm going to speak to the HIV program essentials and the prioritized interventions for consideration and funding requests, both of which are presented in the information note. The next 5 slides present the prioritized interventions proposed for funding through Global Fund. They cover the HIV program areas, which I will briefly summarize. First and foremost, HIV prevention, which is about improving access to and use of precision combination HIV prevention for people at increased risk of HIV infection. There's a strong focus now on scale and coverage, on a highly targeted approach, on stronger systems to deliver HIV prevention, and on specific measurable HIV prevention-related results. We also highlight the importance of increased access to HIV prevention options, provided where and when they are needed. This means that services should be provided from a range of service delivery platforms. These should also include community-based and community-led service delivery platforms to address the needs and preferences of relevant subpopulations. Next slide, HIV testing. So secondly, HIV testing, which focuses on the delivery of a strategic mix of tailored HIV testing modalities and linkage to treatment or prevention. Differentiated models of HIV testing services need to be scaled up in many settings to achieve global targets. And we would encourage to include innovative testing approaches. The information note recommends 13 interventions and approaches for prioritization. Next slide, please. HIV treatment. It covers accelerated and optimized ART using regimens that are recommended by the WHO, increased access to routine viral load testing for treatment monitoring in facility and community service delivery settings. It covers differentiated services for HIV treatment and care. There's now an emphasis on the support to health and longevity among people living with HIV. So my colleague Lee has just explained to you that this guidance related to health and longevity will be published very soon. And our focus on continuity of treatment and return to care has also increased, which is a commitment to achieving sustainable treatment outcomes and the third 95. Next slide. The elimination of vertical transmission of HIV, syphilis, and hepatitis is now expanded from the current focus on the prevention of mother-to-child transmission of HIV alone, to supporting the recommendations of the Global Triple Elimination Initiative, and thereby using an integrated approach to eliminate vertical transmission of HIV, syphilis, and hepatitis B. We continue to address co-infection as a priority, and my colleagues from the TB team will also elaborate on this. With regards to strategic information, sorry, I didn't mention that you need to move slides, but I think you have done that. Thank you. Strategic information. There's now a strong focus on data for impact and enhanced information flows through improved program monitoring and reporting systems. And finally, next slide. We continue to highlight the critical importance of removing human rights and gender-related barriers to services. And we are presenting 8 interventions and approaches to address these barriers for inclusion in Global Fund funding requests. There's clearly a lot, and likely that all these prioritized interventions can be included in funding requests. So what to do with all these priorities? The decision on the interventions to be included in the funding request should be made based on the country's epidemiology and specific context, as well, of course, on the funding envelope available. And the section on the investment approach, which I had presented earlier, describes the steps for the prioritization process. And next slide, please. Program essentials. Yes, we'll move back to the first one, please. Yes. So I'm now coming to my last slide, which are about the program essentials for HIV. So you already heard from Celeste on the program essentials and more generally. So this is much more specific to HIV. So the HIV program essentials are key evidence-based interventions and approaches that to address the ambitious goals set out in the HIV-related strategies and technical guidance, such as from UNAIDS, the WHO, and the Global Fund. The HIV program essentials span across the intervention areas which I have just presented, which are prevention, testing, treatment and care, elimination of vertical transmission, TB HIV, differentiated service delivery, and human rights. They have all been developed in collaboration with our HIV technical partners, and they're also aligned to the respective technical guidance. All program essentials are part of the prioritized interventions, which I had spoken to earlier, and they're clearly labeled as such in the tables in the lists of prioritized interventions. And lastly, and as mentioned by Celeste before, in the HIV funding requests, applicants are now required to outline how advanced the country is in the implementation of each of the program essentials. And in those countries that do not fulfill the HIV program essentials, will describe it in the funding request narrative, the steps to addressing them over time, and this applies to high impact and core countries only. And with that, I'm handing over to my colleague Aura, who will now speak to the modular framework. Thank you.
Thank you, Annette. Yes, let's now focus on the modular framework. As mentioned before, as you can see, this slide shows that the modular framework is very interconnected with other guidance documents from the Global Fund and also reflects the global guidance. Here you can see some examples, and you can use this slide as a resource as it includes all the hyperlinks. Next slide. So this slide is about the revision process and the updates of the modular framework. The revision aimed to accomplish 3 major objectives. The first one was the alignment with the new Global Fund strategy. The second one was to align with the new and most updated global strategy and guidelines. And the third one was to streamline the modular framework where possible. On the first point, to align with the new Global Fund strategy, the modular framework reflects the focus on precision public health, the need for improved and intensified prevention investments, and the Global Fund's commitment to advanced disease and sexual and reproductive health. Precision HIV prevention now is a priority in the new strategy, and changes to the modular framework address this priority. Additionally, the modular framework now also encourages budgeting for access to prevention options via low threshold and non-facility platforms, such as digital, community, or all self-care. Under the second point, the blue one on the sky, on the slide, not the sky, the revision to align with global strategy and technical guidance was mostly related to the revision of the language and the activity description. And a key improvement was the streamlined reporting, which enables more accurate tracking and of budget dedicated to the key areas. We addressed duplications, and overall we were able to reduce the number of interventions from 136 in NFN3 to 84 in the next cycle, 85, sorry. Next slide. So this slide offers an overview of the grant cycle 7 of the HIV modules and intervention. So next cycle, we will have in total 13 HIV modules, of which 7 are dedicated to HIV prevention by priority population. For prevention, this represents a structural change. We removed the population tab and we went back to NFN2-like structure with prevention modules by priority populations, including the 5 key population and their sexual partners, the AGYW and their male sexual partners, and the other vulnerable population group. In the testing module, the main change is the shift from the population to the program approach to improve data quality. We went from 32 interventions to 9, and this will allow to track budget by KP program, AGYW programs, and programs outside of key population and AGYW in combination with the service delivery modality. So facility-based testing, community-based testing, and self-testing. In the elimination of vertical transmission module, which is the former PMTCT module that was transferred, we moved beyond the 4 prongs. And here the list of intervention is completely new. For what concerns the treatment module, a relevant change is the split between adults and children that is now required in the HIV and care intervention. And we have a new intervention on advanced disease. The TB HIV1, we have a shorter list of intervention. We went from 12 in NFM3 to 6 in grant cycle 7. And in the human rights module, the list of intervention didn't change, but the language has been updated. Lastly, the bar at the bottom reminds us that the HIV modules will need to be complemented by the cross-cutting modules, such as RSSH and program management. But the RSSH section in the modular framework includes the complete list of RSSH model, and you'll see later in this session the complete list. The program management module didn't change compared to the previous cycle, but however, the activities related to strengthening national HIV prevention program stewardship should now be included under the related module in the HIV modular framework, which is the prevention program stewardship. So this was a quick summary of the key points and changes. More detailed slides are at the bottom. So this was the end of the presentation. I think we can now start with the Q&A. Thank you.
Thank you, Aura, and thank you, Annette. So we'll quickly go over to the Q&A slides shortly. I think we have a handful there. We will project in one moment. There we are. And I'll hand the floor back to you both.
Sorry, could you please read the questions? That would be great. The first one.
So for prevention, can you hear me? For prevention.
Have interpretation interpret that into English?
That's the one in French. I think that's
Yeah. So
would still fund mass media prevention messages. So I think I mean, it's hard to present all this in a 10-minute presentation, but when you read the information note, it's very clear. And when you read the strategy of the Global Fund, that this is let's say, a new era, precision public health. So we would really encourage very targeted, very client-centered interventions. And I think that applies particularly to HIV prevention. And when you look at the modular framework, which Aura just presented, this is now broken down into very specific subpopulations of key populations or AGYW. So it's a highly precise approach. And also, therefore, the request to really look to encourage you to constantly look at your data and come with a wealth of data, so you analyze your response in line with the data. Having given you this long introduction, we would not be very supportive of mass media type of interventions, and I think we should much rather to focus on prevention, communication, and demand creation to provide access and use HIV prevention options. Over. Hold on, what is the next one? I think this is on the new products. Well, we're not asking countries to assess, have a very large assessment in detail, but I think I mean, there are always benefits, and I think this is once an intervention or new product is recommended by the WHO, and I'm not only referring to treatment. So there are a wealth of new prevention products. There are new testing platforms. So I think it's all this, and of course, every new tool comes with an upfront investment. But I think it's this balancing, not to say we can't afford a new tool, a new product. I think what's important to then also see, where could I save? I mean, if you have better treatment options, for example, how many lives can you actually save? How many people are not becoming resistant to a certain drug? And of course, second line treatments have always up to a certain point always been more expensive. So I think it's this balancing, not just simply say we can't afford it, because in the end, I think that's what counts. It's this taking into account other parts of a program aspect. And if there is a need or the country decides to perform studies, that we do fund operational research. So we're not funding clinical research, but we do fund operational research. And if that's what's needed, then I think we would be funding it. But we encourage countries to move fairly fast with the introduction of new products and tools. Thank you.
Very quickly, before we move further into the questions, just a kind reminder to those answering the questions that for those attending in listening in Spanish or French, if you could please read the question aloud so that it gets interpreted into the other languages. Thank you.
Okay. So then there's one. The supported interventions for HIV seem verticalized and weak on the aspect of integration of HIV responses. Is there additional guidance on integrating the responses within the health system? So first of all, let me tell you the information note is not a technical guidance document. So this is really, we are compiling the most high impact interventions that have been that are recommended by our technical partners. And there is also, in many of the sections, there is, and I think also Lee spoke to that in a bit more detail, there's also reference to integration of services. And I think that will be, of course, certainly, it's very, very important. But please bear with us. My colleague Olga from the RSSH team, she will probably also be referring to the integration of the HIV responses. But yes, you're right. There is a strong focus on integration also. Thank you.
So Annette, if you allow me and you can hear me, I just want to add that integration is such an important part of our strategy and of our information, HIV information note, that you will see it across all the areas, but we will refer to the RSSH guidance, and we will also refer to integrated service delivery guidance, which is the health and longevity that focuses on co-infections and comorbidity, in addition to what my colleague Annette has just mentioned. Over to you.
Hi, all. Jumping in, we're going a bit over time. Perhaps you can just have one more question, and then we can move on to tuberculosis, if that's okay with you, Annette.
Sure.
Thank you.
Hold on, let me check.
Annette, maybe I can take the fourth question on
Yeah, sure, go ahead.
stewardship.
Please. Yes.
So if the question is, how would you define stewardship? We mentioned this for the prevention, right? So we have this new module on prevention program stewardship, and you can consult it on the modular framework. And it refers to all that is needed to scale up precision prevention service delivery, from the development of national prevention strategy, target setting, definition of costing, capacity development, last mile supply. So you can see there some of the examples in the activity description, one of which, by the way, is integration of HIV prevention into to the promotion of SRH services, just to link with what Lee was saying and Annette was saying on the previous question.
Great, thank you, Aura. So if you guys could copy or answer the questions in the chat if you have some capacity for this. If not, we can try to copy and paste them if we have time at the end of the session to address them live. So with that, thank you both, and we'll go on to the tuberculosis information note with Jamie.
All right, I hope you can hear me and see me well, because I'm not in with you all. So my name is Jamie Townsing, and I'm the Senior Disease Advisor for Tuberculosis at the Global Fund. I will be speaking to the updates to the TB information note. Next, please. Much like HIV or TB, also we have key changes to the TB-related materials. The information note, which I will be speaking about now. There is also an update to the modular framework handbook, to streamline and to create new modules to be able to track our investment better. I'll speak slightly to that. And then there's the essential data tables that Celeste described nicely. This was updated and revised in the context of program essentials for TB. Next, please. So this is the outline of the TB information note, and you will see that there is the investment approach, prioritize intervention, good practices. I will be mostly speaking to section 3 and a little bit on section 1 on the investment information note. But please go through the information note for the 4th section, for country examples, observations from technical review panels. That will be very helpful as you develop your funding requests, to know what the TRP likes and does not like to see in the funding request. Next, please. So I will not repeat this much because it is very similar to what my colleague Annette presented for HIV. We also, for TB funding requests, it has to be informed by a good understanding of the epidemic and the resource needs. And these ones, should lead to a good design, mix of interventions that maximize impact, and they are delivered in a manner that is efficient and that is of high quality, always considering the very important issue of sustainability so that this remains to be funded even after global funding ceases to exist. Next, please. So the next couple of slides I'll be speaking to what are the priority interventions for Global Fund investment. And these are very much like HIV. These are impactful interventions that are recommended by Global Fund and by its technical partners. And the first set of slides focuses on screening and diagnosis. So on screening and diagnosis, the priority interventions are diagnostic network strengthening to address the gap that limit access to and utilize diagnostic services. So we need to make, this could be in the form of optimizing services. This could be in the form of scaling up new diagnostic centers, but the end point here is how to improve access to diagnostic services. Another very important point in terms of gaining efficiency is how can we integrate testing for TB with other diseases? This could, for example, in the context of COVID, we were promoting testing for both TB and SARS-CoV-2, but it is also very true for TB and HIV, TB and diabetes, other conditions and comorbidities that are linked to TB. And importantly, also we need to decentralize screening and testing into primary healthcare, community outreach service, example through mobile clinics, as also another means to improve access to diagnosis. On the right-hand side in the boxes in blue are what are the components more on the commodity sides and the new product sides that we want to invest in. And these are also all part of the program essentials that for TB that Celeste referred to earlier. So this, for example, we want use of digital chest X-rays and computer-aided detection software. This is because this is much more sensitive than screening people with TB using symptom screen. And we have good technologies that are WHO recommended now. So how can we scale that up more? We've been for some time promoting scale up of molecular WHO recommended rapid diagnostics like GeneXpert, TrueNat, but the progress is not commensurate with what we want to see. So how do we move from the global rate of 33% coverage with these tests to 60, 70% in the coming 3-year cycle? Also related to diagnosis, we want to see use of other samples like sputum, especially for children. We want more use of bacteriological confirmation rather than clinical diagnosis. And we want to see scale up of drug susceptibility testing to inform the right treatment for TB. Next. This slide is on treatment and care. And I think what we're trying to get to here is how can we improve treatment success rate? How can we enable treatment adherence? A key to that is managing adverse drug reactions. If they have other diseases, comorbidities, we also need to take care of that, provide psychosocial and nutritional support, particularly for those people who need it the most. This could be directly through the grant, but it should also be through linkages to already existing government-funded social protection services. So TB patients are included as beneficiaries to those. We would like to see even much more further shift to decentralized ambulatory, community, and home-based treatment services, just like we want for the diagnostics, also for treatment. We would like to see scale up of digital tools for treatment adherence, but beyond that, for example, we are seeing much more telemedicine, teleconsultation trainings that are happening digitally, even big meetings, supervision. So if those are options that works more efficient, then I think that is a good way to do. There is a technical brief special developed by the Global Data Task Forces, which you may look at with the link provided there. And these ones, the one on the blue box related to program essentials, is to provide shorter and more patient-friendly treatment regimens for drug-susceptible TB, For children, now there are pediatric fixed dose combinations, dispersible tablets. We want those to be available to children instead of adult medicines that are broken down and given it to children in a very cumbersome manner. And for drug-resistant TB, really shift to safer, shorter, all-oral regimens. Next, please. On TB prevention, what are the priority interventions for Global Fund investments? We want TB preventive treatment to be scaled up. We're not doing well on that aspect, especially for children under 5 years. We're doing better among people living with HIV. So as a means to scale this up, I think, and also as a way to be more efficient, can we look at models that integrate ongoing activities, as integrate TPT as a part of ongoing activities, as a continuum of care? For example, many countries spend a lot of money on contact investigation or active case finding. So in these interventions, let us not stop at finding people who are sick with TB, but also find people who can benefit from TB preventive treatment. There is an issue with TPT because in many instances, we are promoting medicines to people who are not sick, but to prevent them, those who have infection from falling sick with TB. So there is sometimes we face hesitancy from the provider side, but also from people who are beneficiaries on that. We need to address those. And I think one way, other than good communications, good community awareness, is to make available shorter regimens for TB preventive treatment and to support people to complete their treatment. So instead of giving a 6 months or 9 months INH regimen, there is now a 12-dose 3-HP regimen, for example, that should make treatment completion and acceptability much better. On the right side, again, like in other slides, are related to our program essentials, rapid scale-up of screening and evaluation of all household contacts, people living with HIV and other risk groups, high-risk groups for TB infection, improve access to TB infection testing, increase the coverage and adherence to TBT, and importantly, many countries, there is an issue with data availability of data for TPT. We need to make sure our M&E systems are strengthened to be able to report on TPT data. Next, please. On drug resistant, I think a lot of them are already included, but I did want to put it together in one slide, just as a reminder. We need to scale up rapid molecular diagnostics and drug susceptibility testing. So we diagnose DRTB much earlier. We need to decentralize testing and treatment services so that not everybody with DRTB needs to go to the district hospital or to a referral center. We need to build local capacity for them to do the tests and start them on treatment, so we do not lose patients during particularly for initial loss to follow up. We need to scale up WHO recommended shorter, safer regimen, including the very exciting new BPAL-M regimens, which are only for 6 months now. And of course, if people are not eligible for that, then the 9-month all-oral bedaquiline-containing regimen. Next, please. Key and vulnerable populations, very important for us because we need, and we know that we have a broad idea of who these groups are in have population attributable factor, what proportion of them lead to the number of TB. But we need to make sure this is a very country context specific. So in every country, we encourage people to look at the size, the location, special needs of your key populations, what are the barriers that they face in other carriers, and then addressing those barriers. Cross-border policies should be in place, especially between countries where there's high movement across the border. And let's not forget that our healthcare workers, they are another key, very high risk groups for TB. They should be properly equipped with good infection prevention and control measures, so they have a safe working environment. They should have good regular access to TB screening, and they should be supported to treat that, to complete their treatment if they do fall ill. Next, please. This is on collaboration, and I think we all know that, for example, in many high TB burden countries, more than half of the people with TB seek care in private sector. So critical to engage private sector. There are interesting models or innovative models that are now being used, including contracting, results-based payment, intermediary agencies. Please think of those if you are in a country with a high private sector setting. Within health programs, there are opportunities to collaborate to improve TB case finding, especially related to mental health, non-communicable disease, for example, diabetes, smoking, alcohol, because these are all also risk groups for TB. And also outside of the healthcare health program sector, can we work with ministries and departments like that are involved in social health insurance and also social health protection schemes, so that we are able to address the catastrophic costs due to TB faced by many patients. Next, please. On TB HIV collaborative activities, this has been touched on, no big change, except that we want ART coverage to be high, prophylaxis to be available, that people with HIV should be regularly screened for TB. If they did not have TB, then if they're eligible, start them on TB treatment, otherwise consider them for TPT. On community systems and response, we need to strengthen the institutional capacity and leadership of TB community-based and led organizations, including now in many countries, we see networks of TB survivors beginning to form. We have to scale up effective and quality community-led and community-based service delivery to improve access to quality. And also, we also need to think about how can we improve outreach services through support of community-based organization. There's a link to the technical brief on this area provided in the slide. Next, please. On human rights, equity, and gender-related barriers, very similar to HIV slide. We do in TB also have issues with stigma and discrimination that needs to be addressed. Always people-centered and rights-based TB services at health facilities, rights-based law enforcement practices. We need to promote legal literacy, access to justice, and monitor policies, regulations, and laws. We also need interventions to reduce TB-related gender discrimination, harmful gender norms, and violence. We do have technical guide brief on this, which you can refer to. On strategic information, I think we've been saying this for some time now. If we are able to do this for COVID, why can't we do it for other things, right? So real-time case-based TB disease surveillance system that inform this decision-making and actions, using disaggregated data to understand the gaps and to inform differentiated response, and then improving really the reporting, data reporting from private sector, community health services, community-led monitoring, so that we are able to quantify and understand the contributions by partnering with these organizations. Next, please. I won't read through this slide. It is just to tell you that in the information note, we have this list of new products and innovations, which we consider a priority and should be adopted and scale up. You have products all across the care cascade. Please do consider these. Whatever is relevant in your context, you are most encouraged to include them in your funding requests. Next, please. This is my last slide, quickly just to mention that like in HIV, our modular framework has been updated and revised. There were 4 modules in the past. So on my left side of the screen, we used to have TB prevention and care. Now it's been split into prevention has been split as a separate module now. So we have the 4 existing modules which are on the left side, but on the right side, you will see a new prevention module, a new module on key and vulnerable population, and a new module on collaborating with other providers and sectors. And related to these, there are indicator changes, which you can look at further through the link I shared in the earlier section of the slide. Let me stop there. Thank you very much. And back to you, Nicole.
Thank you, Jamie. I see we have one question or a few that just came into the chat about X-rays. So my team will quickly pop that into the next slide, but it might take a second. I can read it out loud though, so we can get started.
Yeah.
And if you can go to the next slide, please. Oh, there it is. I'll hand it over to you then, Jamie.
Sure. So the question is around X-rays. Why are we planning to scale up X-ray instead of microscopic diagnosis? And are we planning to introduce stationary X-ray or portable X-ray? Do we have any elite X-ray manufacturers? So that's a good question. And I think, let me begin by clarifying, we are promoting X-ray not for diagnosis, but for screening, right? So we will use this X-ray for screening, and if their X-ray is abnormal, then they should be confirmed through a test. In the past, it used to be sputum microscope. We don't encourage that anymore. We are saying, in fact, replace that and go on to offer patients rapid molecular tests. Right now, we have GeneXpert and TrueNat. So screening by X-ray and then expert. So that's the scale for X-ray is not for diagnosis, but for screening on the first question. And we are planning to introduce both stationary and portable X-ray. It depends on what the country needs. Maybe in a big TB hospital, they need stationary X-ray. But if you are doing, for example, active case finding, targeting remote populations to an outreach mode, maybe that time you need portable X-rays. And we have very good X-ray. We have X-ray manufacturers. We have people who are all able to offer the AI, the CAD instrument that reads the X-ray. You can find them in the diagnostic catalog of the Global Drug Facility. Top of my mind, I can think of at least 2 manufacturers which are listed in GDF catalog, but there are many more manufacturers that are coming up. There's another question there, but I will need translation with that. Yeah.
So yes, it says, would performance-based motivation for private structures be eligible as an activity?
So yes, with private sector engagement, indeed, many models do have incentives tied to that. If that is the policy of the National TB Program, then it is eligible. So it very much depends on if a country is, I can give you an example that I know of India, for example. Anybody, whether it's public or private, who notifies the TB patients to the TB program, they get X amount of money. If they report that the patient they're diagnosed has completed treatment, they get X amount of money. But this is a cash-based incentive system that they have there. But they also non-cash-based incentives, recognitions, awards, many things. So it depends on the country, what is their policy, what is their what is their program, what is in their national strategic plan, what's in their guidelines, and if it's aligned to do that, Global Fund does fund some of those. Yeah. I see a third question there from Fungai Kavenga. In the NFM4, will Global Fund be able to support introduction of AI CAT for digital X-ray machines that were bought by GF Investment in the past? Yes, if I understand correctly, we are prioritizing AI CAT, artificial intelligence, computer-aided diagnosis for X-ray. It is a priority intervention for the Global Fund for the next funding cycle, NFM4. So if there is a need, and if you are just able to justify that you need additional X-ray machines with AI CAT, it is a priority intervention and we can fund it. But you mentioned that there have been but you have to consider what you already have. If Global Fund investment in the past through C19RM or through the regular grant, I know many countries have bought it. So you have to have a proper scale-up plan, right? How many X-rays do you need? Where are you now? Where do you want to get at? So if it is part of the proper expansion plan and can be justified, it is indeed a priority intervention and a program essential that is eligible for Global Fund funding. I see a fourth question from Sabrina Regent. In order to have sputum analyzed by gene expert, you need good quality of sputum, which is not always the case. What alternative method do you recommend to screen? It is a good question. Yeah, I think also true for any microbiological test, whether you do need a good quality of sputum, which is not always the case. And what Global Fund is actually a financing institution, right? So we depend on our technical partners to provide the technical guidance. We depend on our countries and our experts in countries to design NSPs that fits their need. And so if it is within the country guideline, if the alternative method that they want to use that is in their guideline and NSPs and recommended by partners, it is eligible for funding. But I can give you an example of children. So in children, because there aren't many children, especially those below 10 years, can't give you sputum quality. So we have increasingly, many times in many countries, we see reliance on both X-rays and then clinical diagnosis, especially for children who cannot provide a sputum diagnosis. So there has to be a proper algorithm defining the role of X-rays and clinical signs and symptoms. There could be a scoring system that they use, for example, to diagnose whether X-ray or not, right? And another thing that I did mention in my presentation is for children, especially, WHO has recommended that we can use sputum stool samples, non-sputum samples. For children, stool samples tested on X-ray is a recommended testing method, and we do support that.
Thank you, Jamie. So with that, I think we're at time and we can move on to the malaria portion of our presentation. So over to Patrick.
Thank you very much, everyone, and thank you to all the speakers who have spoken before me. I think you made my work much easier. Next slide. My name is Patrick Okello. I'll be speaking on behalf of the malaria team. I'm one of the senior malaria advisors, and I believe in the panelists, I have one of my colleagues, Maud Robertson, to help me to answer some of the questions. Unlike all the other presentations, we have the malaria information note, which is available online, and the modular framework, which we revised slightly, and we'll hope to publish additional resources later on and also translate them into other languages. But all of this will be available in the website. Next slide, please. And for the malaria information note, we purposely made sure it is short enough for you to read, just about 30 pages. And it's really to complement normative guidance. All of it comes from either WHO main guidance or partner guidance like PMI and so forth. And really picking and highlighting the key recommendations that we hope you will include in your funding requests so that they are aligned to your NSPs. And of course, linked to the whole issue of program essentials that all my colleagues have spoken to. So within malaria also, we do have a list of program essentials that we hope you'll follow. Next slide, please. So in terms of the investment approach, I think the main message will be that we hope you will take your country context. You must be very busy now doing either program reviews or risk mapping or stratifications so that you're able to come up with an optimal intervention mix that you'll use and suggest in your funding request. However, we encourage you to look at how these are linked to the program essentials, how far you are in that chain. And in particular, we hope, knowing that in any given context, malaria will not be the same across all countries and all regions in your country. So we hope you'll be able to use stratification to achieve some national tailoring of your interventions. And for us in malaria, I think if you're thinking about integration, it's really RSSH that is the bedrock or foundation for delivery of malaria interventions. So my presentation and the next one are very much linked in that sense, as we rely on RSSH to ensure effective delivery of malaria interventions. What's new is the protection for sexual exploitation and abuse and harassment, which is cutting across the entire grant life cycle. And as peers, I believe there will be sessions on this to all of you. But also, in the past, we thought there were no gender or human rights issues, but now we know there are really some of these are really touching in many of our environments. And this is something that we will describe a little bit more in the information note. Next slide. And for purposes of the information note, we decided to categorize it in two main areas. So we have 5 main areas of investment, which includes the data for the decision making, the usual vector control, preventive therapies, case management, and malaria elimination. And then we have a range of cross-cutting considerations, including gender equity, SBCC, urban malaria. We know malaria is a big issue in challenging operating environments, emergencies, program management, and of course, how we need to sustain malaria response given the investment before, now, and in the future. Next slide, please. So just speaking to each of them specifically, for decision making, we hope that the resources can go into supporting all of you to build very good malaria data repositories, which are interoperable with existing information systems, and that using that information, you're able to do subnational tailoring and generate the data necessary to help us to place the right interventions in the right place subnationally. And of course, that these are people-centered and ensuring that they are available quality commodities to ensure that we have these data systems to help us to evaluate our work, and we'll be supporting a range of these data systems, including HMIS, surveillance systems, surveys as usual. So this part is what we have been doing, and all of this is linked to RSSH investments. Next slide, please. For vector control, we don't have many new interventions, but just to point out that if you're to think about this, it's really the national vector control strategy, which will tell you where you want to deploy different interventions, be they ITNs or IRS. But specifically for ITNs, we're happy to introduce the new dual AI active ingredient nets that we hope the new WHO policy should be available by the first quarter of next year. And this will help you address insect resistance, which is a big issue. And of course, in the recent past, particularly in the Horn of Africa and spreading across Africa, is the new invasive Anopheles stevensii. So to help us address all of these, we really would encourage you to involve a lot of entomological surveillance so that we have the information necessary to help us address resistance and link all of this to capacity building activities. For supplementary interventions, while we recognize their importance, we follow WHO guidance, like on larval source management. We have to fulfill the 3 conditions of fixed, few, and findable. And generally, the advice is let's first fully ensure that we fund the conventional approaches, ITNs and IRS, before we can probably open up to the other, if funding allows, to the other supplementary interventions. Next slide. For preventive therapies, we have had the improved or new guidance from WHO in the areas of SMC, seasonal malaria chemoprevention, on perennial malaria prevention, previously IPTPI, and of course, the usual prevention of malaria in pregnancy. So for this, there is new guidance available in WHO, and we hope you'll have opportunity to look at that. And using your country data, be able to determine where this can be applied. Next slide. For mass drug administration, as you all know, there are really 2 main occasions when this is recommended. One in emergency burden reduction, if there are outbreaks or emergencies of other types. And then 2, in the intensified elimination efforts, we can deploy mass drug administration. However, we do know that its effect wanes within 1 to 3 months. So therefore, you must be, if you are doing this either in emergency burden reduction or in elimination efforts, it's combined with a very robust malaria elimination program. Currently, WHO does not recommend mass relapse prevention of PV, so that will not be funded. What's new also is the RTSS vaccine for malaria. However, in this cycle, Global Fund will not be supporting it. We're leaving it to our partner Gavi that will work with you. However, we're happy to fund the other elements that you can support its introduction. We'll support the inclusion of it in the NSPs if necessary, and of course, support you in the necessary malaria program reviews. Next slide. As I previously mentioned, all of our work in malaria is really underpinned by our investments in RSSH if you are to have a successful malaria program. And this will touch on 4 elements: the health products management, which takes you to quantification, planning, regulatory systems, the human resources for health, and for malaria, we work from community level through the health system, the private sector, and all those levels, and data systems that, and we're encouraging a lot of this in terms of using data for digitalization of campaigns, of supply chain, geospatial mapping or coverage surveys, and very, very much importantly, the community systems that underpin most of the malaria prevention and case management services. And of course, you cannot do any of this without a strong health financing system within the country. Next slide. For case management, the usual 2 are the main ones, diagnosis and treatment. However, the key point here is to understand for all the different segments of our communities, are there barriers that are affecting diagnosis and treatment? And how do we increase those platforms to be able to reach other people? The other important point is really how to ensure there is continuous quality improvement and accurate surveillance within all the spheres of case management, be they public, private, or community. So this is really important, and in the new strategy, we speak very strongly about strengthening the private sector where it's appropriate. And for ICCM or community case management, we have a big win in this cycle in that if resources are allowed, we encourage you to have integrated package that includes together 2 diseases, pneumonia and diarrhea. And now we allow malaria funding to go to buy those commodities. Next slide. This is linked again to RSSH. Next slide. For areas that happily are reaching malaria elimination, of course, as you all know, it's really making sure we optimize vector control and case management by really ensuring we support local stratification. So we identify those key characteristics and populations that remain the carriers of malaria, and they, of course, underpinned by very strong surveillance systems so that we can quickly detect both symptomatic and asymptomatic cases, notify them, and prepare the countries basically for certification for pre-elimination. But all of this, to sustain all those gains, you again need very strong investments in the RSSH pillars of data and as mentioned, prevention and case management systems. And all of this must be under the bedrock of good governance, health financing, and sustainability planning. Next slide. I mentioned that there were some cross-cutting areas. I will not go into detail, but just mention we need to pay attention to equality and human rights. We need to pay attention to community engagement and SBCC. Next slide. As you very well know, pandemic preparedness, we have just come out of COVID, and there are very many similarities between the components that you need to be able to identify new pandemics, and malaria, if you use fever as an entry point. And in the world we live today, climate's an important factor. It's changing our epidemiology and the malaria-genic potential of our different area. So we need to be able to have access to climate data and include it in our malaria data repositories. And of course, urban malaria, which is also linked to the point I mentioned earlier of Anopheles stephensi, which is spreading across Africa. Next slide. And in many areas, whenever emergencies happen, one of the next additional ones will be either diarrhea or malaria. So this is an important one. And of course, program management will be strongly supported just to make sure we look at both national and subnational levels so that we have the capacities to be able to deliver our malaria response in a very sustainable way. Next slide. Briefly on modular framework, next slide. What we did was to align it to the next Global Fund strategy, and looked a little bit more to see other areas that need the refining and improvement. We did a very wide partner consultation, both internally and externally. The good news is that we don't have many changes on the malaria modules, other than really to integrate the much more streamlined WHO recommendations and language, so that what's in the modules is very much aligned to the WHO guidance. And we do also link what we have in malaria modular framework to the cross-reference with the modules in RSSH. Next slide. Let me end with this slide and just say for the indicators, what's really new is a strong emphasis on the subnational level. So we hope that as you look at vector control, case management, you're looking at the subnational levels so that we're able to measure what changes are happening at those levels. And for specific prevention interventions, it's really to align to the new WHO language. And for elimination, is to better track how countries are ensuring local transmission. They were able to know that there are now no more cases and we can prevent the introduction. I think this should be the last slide for malaria, and happy to take your questions, and my colleague Molly is available to help. Thank you very much.
Thank you, Patrick. I believe on the next slide, we have a few questions from the chat, and I think I saw someone internally with their hand raised. Anna, did you want to speak, or would you like to save it for after the questions are addressed? Okay, I'll hand it over to you, Patrick, then for the questions.
If I can start, Nora, your question is, you emphasized on RSSH to support malaria programs. Yes, however, often RSSH is combined with the TB HIV in many countries. When RSSH parts developed malaria program is absent, you find they have already developed a proposal, nothing can be changed. Are you planning any changes in the proposal development process and recommendations of peership for RSSH in NFM4? I think, thank you for highlighting some of the problems that do exist sometimes at country level. Our hope is that the way we have written both the RSSH information note and the malaria information note are very much linked, and they do emphasize the relationship and the underpinning that RSSH brings to malaria. So we're hoping that your country dialogue will take this into consideration. And given that we have a much narrower envelope this time, the need and the value for integration will be really important and can be seen by all actors. So this really, I think I agree with you, the plea for us to make sure we work together closely between malaria and RSSH and the other diseases. Prince, just be very clear on indoor retail spraying. For it to be successful, we need to have it done for at least 5 consecutive years. What's the guidance, knowing pretty sure that the grant period is 3 years? What the language you'll see in the information note is that we advise any country before you initiate an IRS program to have sustainable financing mechanism. As you rightly point out, that should be there for a longer period of time. Otherwise, the experience, and it has happened over and over, is that as soon as you discontinue the IRS program due to funding, often you're just going to have a rebound of malaria. So your point, Prince, is very clear also in the information note. Komi, I will need a translation here. I don't speak French, sadly.
Yes, the question says, within the framework of ICCM, will the purchase of other inputs other than malaria inputs, paracetamol, amoxicillin, zinc, etc., will be now financed by the GF?
Yes, I just said that one of the big wins of NFM4 is now the Global Fund has opened up to countries to use Global Fund resources to, in addition to malaria, be able to provide the other commodities for diarrhea and pneumonia. So yes. And Hilaire Zone, your question, you wanted to make sure GF will support procurement vaccine commodities? Yes. And we're all excited with this capability. Not sure if there are any more questions. Oh, yes, Sarah. Interesting to see all these presentations. I was very struck by how much stronger the malaria presentation was on RSS compared to others. Is there a concern that RSS should be funded disproportionately from malaria grants? I hope not. I hope that all the 3 diseases benefit from RSSH. All I was trying to emphasize was that we do strongly believe in the malaria space, that to be able to have good case management, you need a good, strong PHC program and all the other elements of RSSH. But I do hope that within the country's dialogue, all the 3 diseases will strongly support RSSH. Donna Ken, country can plan vaccine introduction with GF grant. As NMCP do not have a close collaboration with Gavi, can you advise? We welcome the new development and the WHO policy on the RTSS, but at the moment, we do feel that the partnership and already the work Gavi has done within the immunization space, they're taking lead on this. The point I was making is that at the moment, we won't be able to have resources from Global Fund go towards procurement of a vaccine or to deploy it. However, we're happy to support any other planning functions that the NMCP would like to invest in, but not necessarily to buy the vaccine or to deploy the vaccine. James, your question is, can we use GF resources to fund second year activity to strengthen those 4? At the moment, no. At the moment, we're really focusing on the main malaria interventions and leaving the malaria vaccine to the efforts of Gavi. I hope that helps. If no other questions, may I kindly invite my colleague Olga to now really give us a wrap-up of RSSH and how all of this fits within the 3 diseases. Over to you, Olga. Thank you.
Okay. Hello, everyone. Sorry, it's a little bit dark. The sun is almost down here in Geneva. So thank you for staying with us. I know this is a long session. I will try to be clear and concise. So the next slide, and maybe just introduce myself. My name is Olga Bornemisa, and I'm one of the senior health systems advisors here at the Global Fund. So I'm going to mostly focus on the information note, but I will reference the modular framework in my presentation. So this is a screenshot of the information note. It's got 4 main areas. So an introduction, then it has a section on the main areas that are covered under RSSH, and that's what I'm going to focus on today. There's some very good illustrative examples of good practice for RSSH, particularly around integration. And then we have some very important annexes, and I really encourage you to look at that. I just mentioned one in the chat. Annex 3, for instance, talks about the ICCM commodities and which countries are eligible and how to sort of go about that. But there are also very good annexes on M&E investments and referrals and quality of care. Okay, so if we go to the next slide, I wanted to pull out a few main strategic messages from the information notes overall. So there's 4 new ones, and then a few that I just wanted to sort of emphasize that are continuing that I'm sure you've all heard before. So the first and main one, and this is sort of, you've heard this from HIV, TB, and malaria, is that we're really working on strengthening integrated people-centered quality health services and systems to improve HIV, TB, and malaria outcomes. And on the right, in the blue, you can see some of the reasons why this is. Now, we focused on this because in the new strategy for the Global Fund, this comes front and center. Maybe just to elaborate a little bit, because I saw some questions earlier, we're focused on both services. So say maternal and child health services to make sure that HIV, TB, and malaria are dealt with in those services, as well as the systems. So the health product management, the laboratory, the human resources for systems, we want to make sure those are also integrated as much as we can going forward. The second main new approach that I'd like to mention is about critical approaches. These are RSSH critical approaches. They're basically similar to the program essentials that HIV, TB, and malaria have developed, but we've only done them for 3 areas: for health product management systems, laboratory systems, and human resources for health systems. And we're going to take a little bit lighter touch than the program essentials in terms of the way that we use them. So we'd like everyone to be aware of them. They basically summarize kind of best practice, and they synthesize very concisely what we want you to focus on going forward in those 3 areas. Of course, you don't need to do all of the critical approaches depending on the country, but we want you to have a look at them. The third area that I want to emphasize is pandemic preparedness, because we haven't really talked about that so much yet. Just to say that RSSH funding can be used to fund pandemic preparedness. This is mostly done through strengthening lab systems, surveillance systems, HRH, health product management, and medical oxygen systems. So, and in the modular framework, these modules are labeled as RSSH/pandemic preparedness. So you can sort of easily see which ones these are. Of course, the C19 funding will continue, and last week at the board, it was extended to the end of 2025. So the C19 funding should also be used, of course, to continue to strengthen the pandemic preparedness. The fourth area, which is not really new, but I just really wanted to highlight, is that we need to continue to improve the way that we measure the impact and the outcomes of our RSSH investments. And we've revised the modular framework to make it much easier to do this. So we've revised both the indicators and the work plan tracking measures. In a certain number of countries, we're also going to be sort of trying to roll out these health facility assessments to make some of the indicators easier to get the data for. So we'll be talking more about that with the individual countries who are eligible for this. Okay, just a few notes on what we want to continue to emphasize. And this goes back a little bit also to some of the questions that we've seen. So we really want to strengthen RSSH country dialogue and representation on the CCM, and I'll talk a bit more about that at the end. We want to continue, and this is really very much pushed by the TRP, a shift from short-term, very input-based health system support where you're really filling gaps, and starting to think more about sort of long-term health system strengthening. What do we need to do in 3 years? What do we want? Where do we want to be in 6 years? Where do we want to be in 9 years? And trying to conceptualize your RSSH within this longer time frame so that it's less fragmented and short-term. And then the final thing is, given the current economic world environment, enhancing value for money is still incredibly important, as well as thinking about sustainability. And I've noted some of the policies in the technical briefs, and there will be a STC sustainability transition co-financing meeting, well, not meeting, but a webinar next Thursday, I think on the 30th of November. Okay, so next slide. So what I'm going to do for the next 8 slides is I'm going to talk you through the 8 main areas. It's going to be quite quick. I won't talk to the right-hand side of the areas supported because of time. So I'm just going to focus on the left-hand side, but please read what I say on the right-hand side too. Okay, so the first thing that we have put in the information note is health sector planning and governance. And we put that first because it's so fundamental to the way that health systems function. So we really want to encourage countries to support this in 4 areas. So first of all, supporting effective planning, leadership, and governance of the health sector, and including the private sector. And I just want to direct you to the right-hand side. I knew I said I wouldn't talk about it, but if you just see the green new, we are including in the modular framework a private sector intervention. And so that will be under this health sector planning and governance. So I just wanted to flag to you, because this is incredibly important for HIV, TB, and malaria, and should be done kind of across or can be done across the diseases. Because of course, the private sector is an enormous provider of health services. And so we need to take them into account. The other 3 areas that we're encouraging you to support is better prioritization and budgeting, especially for the subsector plans on health product management, on lab systems, on HRH, community health, and M&E strategies. We also want to encourage you to focus on and strengthen and take part in discussions on primary healthcare and universal health coverage strategies, and in particular to make sure that HIV, TB, and malaria considerations are taken into account in those kinds of plans with the sort of lens of sustainability. And finally, coming back to the more integrated people-centered quality health services, we would like to facilitate planning for this within these different types of strategies. So if there's a need for it, it is eligible for Global Fund funding. Next slide, please. So again, health financing systems, we put this number 2 in the information note because again, it's so fundamental. It sort of shapes the way that the whole health system works. So we've created, I don't know if you know this, a whole health financing department at the Global Fund. This has gone right up the agenda. And so we're really encouraging countries to use a little bit of their allocation to strengthen the health financing system, in particular, the 3 main health financing functions of resource mobilization, pooling, and strategic purchasing of health services. And you can see below some of the examples of where this money could go towards the health financing strategies, planning, advocacy, and monitoring for domestic resource mobilization, better use and better collection of health financing data using the national health accounts, strengthening public financial management system. Our finance colleagues are very interested in this because we want to make sure that budgets are well formulated and then executed down to the lowest levels, including at the health centers. And then finally, enhancing mechanisms for public financing of civil society organizations, which includes the world of social contracting. Next slide, please. So community systems and responses, this should be very familiar to most of you. We'd like to encourage CCMs and countries to continue to place communities at the center of the response. We'd like to encourage you to really think about designing, costing, and implementing CS&R interventions to really try to improve access to and the quality of the services for HIV, TB, and malaria. There are 3 new tools that I've highlighted at the bottom that have been developed to help you. And these are referenced in the CSS technical brief, as well as upcoming up on the Global Fund website. So I highly encourage, if you're working on this space, to have a look at these. Next slide. Monitoring and evaluation systems are a huge area of investment under RSSH, and we will continue to invest in this area. It's incredibly important to have good data to be able to inform the programs. The 4 main areas, which hasn't really changed so much from before, is that we want to strengthen national HMIS strategies and M&E plans, because these are really foundational for the investments. We want to make sure there's more integrated and interoperable data systems to improve data quality. We want to build capacity for data analysis and use at all levels of the health system. And we want to ensure that you are continuing to assess your M&E systems to identify system strengthening needs and priorities. And again, you can see on the right some of the main areas that are supported under the M&E systems. Next slide. Human resources for health and quality of care. So we are putting more and more emphasis on this area. We have historically funded a lot of human resources for health. What we'd like to do is fund it a little bit more strategically, using a more evidence-based approach and trying to do it in a more sustainable manner. We would like to gradually move away from short-term salary support that is a little bit unlinked from any HRH plans, to make sure that the remuneration is really based on good HRH strategic planning and data analysis. And we also want to, in some countries, scale up workforce development, especially of primary healthcare teams, including of community health workers who are part of the primary healthcare teams. The other thing we want to do is really move away from one-off in-service training, because it's not very effective. And we want to try to put together and push for more packages of training plus quality supportive supervision that uses data for improvement, plus sort of continuous improvement techniques that are used by quality improvement colleagues. As I was saying, we'd like it to be more evidence-based. So there's also this focus on HRH planning, management, and governance, because we need the HRH analysis to be done to inform the policy reforms, because the ultimate aim is to try to optimize the deployment and the skills mix of the human resources for health in the country. And of course, we want to prioritize evidence-based intervention. Just to flag that all of these updates apply to the entire workforce, including community health workers. At the bottom, you'll see a little plus sign and a note that we have critical approaches. So just a reminder that we do have critical approaches that guide this shift, and we've included them just in the interest of time in the annex to this, this PowerPoint that you will receive. And again, the main areas that are supported are summarized on the right. Next slide, please. Health product management systems. This is another area where we continue to fund. The main aim of our investments in HPM is to ensure effective, integrated, and sustainable health product management systems to deliver uninterrupted availability of health products. We really want to focus on ensuring equitable access to quality assured existing and new health products. And we want to make sure this is done in an ethical, environmentally sustainable way with using transparent procurement practices that comply with public procurement standards and value for money. And finally, we would like to strengthen country capacity to accelerate the equitable deployment of and access to the innovations. So again, you can see on the right-hand side what are the main areas supported. It hasn't changed very much since the last cycle. And at the bottom, you can see that there are critical approaches to guide this strategic shift. Next slide, please. Laboratory systems strengthening. So this is an area that has, again, shot up the agenda, I would say, in the last few years. We now have a whole laboratory systems team who are working hard to kind of push the agenda. So basically, the aim of our lab systems investments is to ensure, again, an integrated national laboratory system that can meet the needs of all the diseases. And this will really require the strong national leadership and governance structures to provide coordination and drive integration. So our laboratory team has been working really proactively with national laboratory directorates. They've called them together for a few meetings. And so they are now getting up to speed with Global Fund and how it works. And so we are really encouraging countries to take advantage of the directorate and to encourage them to come to the country dialogue and really take place in the funding request preparations. Two things to emphasize here among many, many things, but the first one is that we really want to focus on updating workforce policies and implementation to institutionalize good lab systems training programs to ensure that we get a next generation of skilled medical laboratory staff, using many of the same good techniques that I was mentioning on the HRH slide, so continuous quality improvements and supervision, et cetera, and finally, just to reiterate again that lab investments can support pandemic and should support pandemic preparedness. Again, you can see the plus sign at the bottom, so there are critical approaches to guide this strategic shift. And again, you can see on the right-hand side some of the main areas that are supported. So the next slide, medical oxygen and respiratory care. So this is a new area that's been added, and it's being added to make sure that we can complement and extend the C19 RM investments. Although given that C19 now will be extended, this may not be as kind of needed as it was prior to last week. But in any case, the RSSH funding can be used to focus on oxygen and respiratory care systems. And it's really to ensure that there's good case management of people who need this respiratory care. Next slide. So this is almost my last slide here. So just to go back to a few things I'd mentioned earlier. First of all, we really think we need to ensure inclusive country dialogue. And that goes back to one of the questions one of our colleagues asked about, having why is the HIV, why is malaria having the, now I forget. But anyway, one of the, there's this sort of disconnect between the diseases, and the RSSH doesn't really feel owned by the diseases. And we really want to try to fix that. And I'll talk about that and how we're going to do that in a bit more. But I think step one is to really make sure that the right people are in the room during the country dialogue. And we've listed some of the possible key stakeholders. The second area is really trying to consider more consolidated RSSH funding requests. The TRP continues to tell us that it's very hard for them to really judge the quality of the RSSH funding request when it's split between all the different funding requests. They really would like it to come together in one, and they'd really like it in the first submitted funding request. And it can be either within a disease-specific request or as a standalone RSSH request. For the few countries that have done it, they've really actually quite liked. They found it very efficient to do one funding request. You don't have to do HIV, TB, and malaria separately. You can bring them all together. So that is allowed and encouraged for countries that might be interested in doing that. The thing that I wanted to highlight here is the revised program split process. For those of you who have joined previous access to funding webinars, we have talked about this. So I just want to flag again that the program split process is now requiring countries and CCMs to indicate the amount for RSSH from their allocations for HIV, TB, and malaria in the program split form, whether you're confirming the program split or changing the program split. Now, what we recommend is that you use the new RSSH priorities and gaps analysis annex, which is on the yellow on the right-hand side here, to inform these program split discussions. So going back to what I was saying a little bit earlier around the country dialogue, we've created this new annex because we want to make sure that all of the disease communities buy into the RSSH investments. So we've kind of laid out a process in this annex, and we'd like the, well, you have to now with the funding request, fill in the annex. So it's basically 3 sections. The first section is where we ask each of the disease communities to fill in what they think are their RSSH priorities. Where do they want to see the RSSH money going to? What do they want? In the second section, we ask for the disease communities to come together in a meeting and have a discussion about what they together want to prioritize, so that everyone is part of the discussion, everyone owns the eventual prioritization of what the RSSH amount is going to be. And then the third section is really the funding gap analysis, so that for the main cost drivers that are selected, you would fill in a quite simple funding gap analysis where you would say, this is how much we want from the Global Fund, this is how much other donors are funding, and this is what the gap is. And so this is how Global Fund's funding is helping fill the gap. So with that, I'll just go to my last slide, which you've seen a few times before, but this just has the link to the RSSH information note. It has the link to the modular framework, and it has the additional resources there on the right. So let me stop now for questions and answers. I can see it's 5:21, so we have about 9 minutes. Thank you very much. And we have a lot of questions. Okay, let me start at the top. So are CCM respiratory timers in the Project Global Fund catalog? This is not CCM, it's ICCM, respiratory timers. Yes, I believe they are, but I will ask malaria colleagues to confirm that, but I am pretty sure that they are included. So from Prince Nakata, he says, RSSH is quite pivotal. However, my observation in the current grants and in the past is that there are no indicators in the performance framework on RSSH where PRs report. Should we expect indicators in RSSH that will form part of reporting for PRs in the performance framework? Yes, absolutely. So we have added more indicators and better indicators into the modular framework. We really encourage countries to try to use them, recognizing that we don't want the PF to become, the performance framework, to become completely overloaded with indicators. But I think at this point, we are very much suffering where we just don't have enough RSSH indicators in the PF. So we are very much encouraging countries to include indicators in the PF. Okay, the next question, Lila Mutiyu. From previous experience, dialogue on RSSH tends to be quite unstructured with unclear processes and main actors that are involved. This may be further complicated by the fact that some of these are conversations are expected to happen before the actual applications are developed, and a lot of critical interventions can be passed under RSSH. Could you please advise on 1, how to better structure these processes, and 2, who is heading these meetings and helps with final decision-making between the different proposals put forward by the 3 programs? Well, that's an excellent question. There is a lot in there. I think we could have a whole meeting on this. But in terms of how to better structure the processes, so 1, that's why we've put together the NX, because we think with those 3 questions that I just went through in the yellow on the right-hand side of the slide, I think that gives a little bit of a structure. As to who heads the meetings, it should be headed by the CCM. I know in past experience, it's often headed by the lead consultants who are organizing whichever funding request is going to hold the RSSH. Often they don't feel like they've got strong ownership over the RSSH. We are trying to educate those consultants. So we are going to the TB meetings, the RBM meetings, the UNAIDS meetings to try to get them on board. Some consultants do this very well. Some consultants really struggle with this. I think this is an ongoing conversation that we need to have. I do think that the technical partners are out there in the countries. We had meetings with FCDO. There's a lot of money going to the French set-asides. We're having meetings with backup. And I think those colleagues could also be called on to help structure some of these discussions as well. Okay, the next question. You emphasized the RSSH for health emergencies, preparedness, and resilience. Oh wait, can I just say one more thing on question 3? Is that we are coming up, we have a pilot being done in Latin America actually on how to do a prioritization process. And I think that the results so far are quite promising. And so it would also be another option to try to use this as a prioritization process for RSSH. So if people are interested, please just email. You can probably find my email through Access to Funding, and I can put you in touch with the right people. Okay, so question 4, and I can see that there's more emails coming in. You emphasized the RSSH for health emergencies, preparedness, and resilience, but you do not see any clear emphasis on this in any of the cross-cutting areas. A brief mention under HR. Would you mind explaining further if you've developed any other guidance documents in relation to this topic in light of the experiences we learned through COVID-19? Because emergencies can be beyond COVID-19. Okay, yes, that is a weakness, I would say, in the current RSSH information note. In the previous one, we actually had sections on COEs, on complex operating environments. And I think because this time we had to cut, even though the RSSH information note is much longer this time, we had to cut that. We will be having a COE meeting for the COE countries in early December, where we will try to provide a bit more guidance on this. So yes, I recognize that it doesn't come out strongly enough. And so we'll try to fix that actually in some of the further discussions and presentations that we do, especially in some of the COE area regions. Like we're going to be doing some work in West and Central Africa. There's a lot of COE countries there. We'll build in that sort of guidance. Okay, next question. Why is X-ray services seemingly missing from RSSH? Yes, it's a key RSSH intervention. So X-rays are covered under the diseases, and that's why it's missing, even though, of course, X-rays can be used for many, many different areas. It's just the way that we classify the information, but yes, point taken. And then the last question from presentation in NFM4, RSSH will be a separated grant request or will be integrated in malaria grant as per previous and current grants. Okay, so let me be clear, it can be either. You can either include the RSSH in a standalone funding request, which will become a standalone RSSH grant, or you can include the RSSH in a disease funding request, and then you can include that RSSH under the PRship of the disease grant, or you can create a standalone RSSH grant out of the disease funding request. So you have to think about funding requests are different from the grants. You can have different types of grants coming out of a disease funding request. So hopefully that's clear. I see one more question, and I see I've got 2 more minutes. Program the split. The way you describe it seems very logical and simple, but believe me, on the ground, it is not. Yes, I do believe you. I know it's not easy. It is very difficult to ask every program to dedicate money out of their budget to RSSH. Unless the Global Fund comes up with a very clear method and strong recommendation on how to prioritize and to what level you allocate funds, it will continue to be the same repetition of the challenges in NFM3. And I'm talking about most countries, not a particular one. Do you have further recommendations to be developed on this topic? Okay, so you're absolutely right. It's not easy to do. The idea of asking for it upfront in the program split is to make sure and to stimulate and incentivize the CCMs and the disease communities to come together and have the conversation. It will be an earmark. So it will be a certain percentage from each of the diseases where they agree, based on their discussion that they have around the annex, that they want to put a certain percentage of the total portfolio towards RSSH. And they don't sort of try to do it as each funding request comes along, and then they think, oh, at the last minute, we should do something about RSSH. So that's why we're going back to doing this. We did this in NFM1. It wasn't easy, but we want to try to do it again and see how it goes. We are under quite a lot of pressure to do more on RSSH, as you've seen with our replenishments. So it's important. And I do think if countries can be a little bit more deliberate, if they can sort of earmark some money up front and then decide together what they want, I think it may, I think it actually will improve the quality of the funding requests that we get. But yeah, it's not easy. And it does take some strong leadership and on this topic. Over.
Thank you so much, Olga, and to all the presenters. So with that, we're at time. I'd like to also reiterate some of the messages that were in the chat. The presentations in English, French, and Spanish will be sent to all the participants who had registered for this event. And the recordings, along with the presentations as well, will be available on iLearn, in addition to the Portuguese translated slides shortly after. So thank you again. I wish you all a good day and evening wherever you may be, and see you on the next webinar. Goodbye.